It's my pleasure to be here back in Wellington. I'm a Wellingtonian. I'm Grant Christie. I'm a Wellingtonian by birth, but born in Wellington Hospital and grew up in the mists of Karori, and ended up training in Dunedin, and then working in London and then Auckland and doing my psychiatric training there, and then moving on to my child and adolescent training there. And whilst I was in that transition phase of moving from my general training to specific child and adolescent training, I was doing a dual diagnosis run, which is an addiction run up there. And beside the DD team, there was a motley crew of 4 or 5 clinicians who were the youth team for CAS, which had been recently formed. And I whilst working with the DD team and knowing I was going to go ahead and do child and adolescent training, I had my eye on these guys across the corridor, and you know, gradually we started talking, and I decided that they, whether they liked it or not, they might kind of need some of my help now and then, and certainly they were asking for it around some difficult kids, and so eventually I sort of earned their trust, if you like, and they let me come in and do a bit of work with them. And so I stayed and did a bit of sort of couple of days a week with them throughout my child and adolescent training, and then worked with them as a junior consultant part-time, whilst I also worked in CAMS teams, and then but more recently I've been there full-time. So and over the time, and so I've been there for about 10 or 11 years, or maybe more. I don't like to think it's any more. And over that time, it's grown from about 5 people through to about 20, and so we're quite a large youth alcohol and drug community outpatient team now. But I guess we have to be. We are regional and we cover the whole of Auckland, which is a large population. So, but I guess it's been my pleasure and privilege to work with that team over that time, and within CADS, the wider CADS organisation, and it's given me a lot of the opportunities that I have, and I guess the ability to be in a position now where I can talk at a thing like this. But I would hope that today and last year when we were there at Parliament, this is kind of, if you like, the end of me, because it's the beginning of, not the end of me, but the beginning of similar services to Alta High being developed around New Zealand, and within that hopefully there'll be passion and expertise developing, and such that, you know, I'll be able to go and retire and hide somewhere under it, and there'll be other people to come up here and talk about it and talk about their vision for the sector. And so, yeah, I'm really excited about that. I'll just put it on the bottom there. We've got alteredhigh.com, and we've just set up a website. Yeah, sorry, it's a bit late. It's sort of about 10 years too late, but that's a informational kind of website where you can read more about Altered High and kind of how we work and what we do. And there's also updates that go to that. There's a sort of blog part of that where we post various bits and pieces that we might be doing or might be happening within the service. So, for example, one of our clinicians has done a sort of cartoon-based info sheet on synthetic highs, and so that kind of thing's up there. So check that out when you get a chance. So, how should we describe services now? Tanya actually gave me a document, Drivers of Crime document, and asked me to comment on it about 4 weeks ago, and I was looking specifically at the youth AOD part, and I came up to the bit where it talked about youth AOD services, and I came across these kind of words, and I thought, oh, I've seen those before, and where I'd seen them was that I'd probably copied them off someone who'd written them before me, like Rhea maybe, or Fraser, and and I'd written them down somewhere, and someone's obviously had taken something from that and copied it somewhere else, and so I thought, enough is enough. We've got to stop talking about youth AOD services in New Zealand in that way, and that's not good. It's not a good example to the sector, and I guess to our clients. We've got to be promoting self-efficacy, optimistic, aspirational. We've got to be talking about, what we hope can be achieved, and have high hopes for our young people in the treatment that we do. And so I'm not going to talk about those old kind of words, even though they were relevant, possibly. But we need to be thinking about how our services are going to be comprehensive, consistent, evidence-based, CEP capable, etc., etc. So what I'm going to talk about today is not so much what youth alcohol and drug services should be look like, because we're going to be talking about that all day. But what I do want to talk about is a little bit about youth AOD and CAMS and how they are similar and how they're different. And I think this is relevant because I think, as Peter was saying, when you think across New Zealand and you think about child and adolescent mental health services, you kind of know what you're talking about. Even though they're different, there's something which is a CAMS, and people kind of understand what that is, and similar with adult CADS and adult mental health. But in terms of you can't sort of conceptualise the same thing in terms of youth AOD at this stage. But hopefully, the Exemplar project is, I think that's kind of encapsulates what it's about, and a sort of identity, and so people know kind of what it is. So I'll talk about that a little bit, and I want to talk about engagement-focused services and a little bit of a gripe about CAPA, which I probably shouldn't, but I will. And I'm going to talk about primary care interventions, because I think that's kind of, we'll have time to talk about that again this afternoon, but I think it's probably be good to introduce that. Okay, so youth AOD and CAM. So this very cute little photo is of twins born to the same mum, and they appear quite different. However, they've got the same genetic building blocks, despite this sort of different appearance. And I'm sure as little girls are completely different from each other in terms of their personalities and their and who they are. But at the same time, they're probably more similar to each other than they are to all their peers and any other person in the world. So. I found this photo and I thought it's kind of a nice way to think about the sort of CAMS and youth AOD kind of like dichotomy, if you like. And an example of how CAMS and youth AOD services might have the same those genetic building blocks being things like, resources, staffing, training, that kind of thing. But an example is a practical example that we've been sorting out in Auckland over the last few years is around detox capacity for youth AOD services. And CAM services have been gradually developing respite facilities for their young people to be who are in distress or on the verge of going into hospital, so that as an alternative to admission, they get put into some sort of respite. And we in Aotearoa were looking at these services and thinking, wow, this is what we need. This would be perfect. We can get our young people in there for a week or so, away from their environment, which is perpetuating their substance use, and detox them. And at first, this was like, well, this is a no-go area. You're an alcohol and drug service. Your young people won't possibly sort of fit in here, or can't, or what have you. But we ended up talking to funders and presenting a case, and as further of these facilities were contracted with different providers, we managed to get put into the contracts that as well as respite for youth, there's capacity for these providers to be use for detox. And then we've been going in and training the respite facility staff to manage detox, and now they enjoy it and they quite like doing it. And now what we're finding, so that's a kind of the youth AOD perspective coming into a CAMS resource, if you like, and using it both ways. But now what we're finding with the CAMS is that they're now detoxing their young people that come through their service in the same facilities. And so there's been that sort of cross-pollination. And furthermore, we're getting to the point now where we've got young people who don't necessarily need detox, but they need some respite from their environment for whatever other reason. And we're sort of using it in a more traditional kind of CAMS kind of way. So youth AOD services and CAMS services, mostly they're going to be similar. And here's a list of some similarities, but I'm sure there's way more. I just sort of got some of them off my head and are similar to the other things we talked about. And they should be similar. And the reason that they should be similar is because the young people, when it boils down to it in the end, they are similar. And so I'll just talk you through this slide, which is the results from a study I did in 2014, years ago probably, and I guess I did this study in response to being a small AOD provider and working with these young people and thinking, and I was working in the service and realising that the young people that we were seeing were really high needs and had lots of kind of difficulties and weren't much different from the CAMS teams. However, over here there was a CAMS, we were just 4 or 5 of us, and over here there was a CAMS team, and the differences between the teams were youth AOD clinicians and a little bit of a psychiatrist. And the CAMS teams were, they had psychologists and OTs, and they had all this expertise, and there was this mismatch. It didn't seem right because the young people seemed similar. And so what we did is we got a self-rating scale called the DUCI, which is a drug use screening inventory, and we asked young people in each of the services to complete it. So we did this prospectively, and these are the results that we had. So we measured their difficulties, if you like, across a range of domains, and the total problems is a summation of all those. And what this, it kind of looks a bit busy, and the bars kind of look different, but actually they're actually the same. So statistically, there's not a great difference between these numbers. So it shows what we all kind of know, that substance use, the young people coming to the substance use service have a similar amount of problems as those come to the mental health service. The statistically significant differences were in these domains: peer relationships, so that's friendship, school functioning, and substance use. And what the results showed is that those young people in the addiction service had more problems. So if anything, the results showed that those attending youth AOD services had more self-reported problems anyway. So yeah, so young people with alcohol and drug problems, they may have the same and report the same kind of difficulties. However, they're more likely, they're not always, but more likely to maybe not see themselves as having specific difficulties, more likely to say things like, I don't have a health program, I'm not crazy, I'm not going to a mental health service, I don't fit in, and are often in trouble, etc. And we know that just from how we work and also from research, that they're more likely to have these features. And we try to understand why similar groups of people may not come into services as well as others. And there's the research talks about something called help-seeking behaviour, and I'm not sure this is quite the right word, and I wonder if we need more new terminology, because a lot of the young people we see, they're not, help-seeking I guess implies that everyone's got a sort of base help-seeking, and some are poor at it and some are much better at it. But the young people that we see many of them aren't help seeking at all. They're not actually. It's not even crossing their mind that they might need help for their difficulties. So I thought of a new term, and I don't know if the research is out. Yeah, but maybe what we need to be thinking about is help. You know, there are some people who just aren't help getters. They just don't. They're very poor at getting it, and we need to be thinking about them, particularly when we're looking at the area of youth AOD. So, coming back to the original thing, youth AOD services, CAMS, similar but different, and I was trying to sort of think, well, in what ways are they different? And here's some, if you like, paradigms across which we can conceptualise this. So obviously an alcohol and drug service is going to have more of an alcohol and drug focus. A CAM service will have a mental health focus. I think alcohol and drug treatment focuses on minimising harm versus treatment of disorder. Of course, this isn't exclusive, but it's kind of, it's more just, if you like, where the more trend of what a service might be doing. I think a youth AOD service is more likely to be mobile versus office-based, and it's more likely to have an engagement focus, whereas a CAM service more of a triage assessment focus. And I think a youth AOD service is more likely to engage primarily with first with the young person and try and engage family through that young person, than a mental health service, which is more likely, but not exclusively, to engage a young person via their family. So the family brings in a young person in with concerns about their health, and then the CAMS team will go about and trying to engage that young person individually, whereas a youth AOD service will be more likely, I would imagine, to be out in a school, for example, get a referral from a school guidance counsellor about a young person, engage with that young person, and then access the family, because we want to access families because treatment's better and it's better for the young people. So we've got this kind of continuum, if you like, but as I said, youth and CAMS and AOD shouldn't be sitting on either end of this. And so where should they sit? Well, I don't know, but I imagine a youth AOD service would kind of sit somewhere there, or maybe a bit further towards the middle, and a CAM service would sit there on the continuum, if you like. Do people get that? People sort of understand where I'm coming from? And I think a system, if you like, a youth mental health and addiction system that operates like that, if you look at it, it's a kind of solid base for which to provide health, and of course there's health and youth health and primary care and stuff, but just thinking about these two paradigms. The alternative, which is to sit services in the middle there, if you imagine that without the stars there, that's, if you like, it's still a good system, but it's less stable, and there's more chance for things to become skewed one way or t'other, you see. And how might that happen? Well, I think if you're running a system with just one service that's doing that's doing AOD and CAMS, it's easy to get sidetracked by acuity, for example. We've got to see the people who are the most unwell, and the most unwell tend to be in the community, perceived anyway by those who are self-harming or suicidal or whatever. And so, if you like, we might end up with a system that's skewed that way. So I guess this is the argument for some separation of the two kind of services. Okay, so the second thing I want to talk about is engagement-focused services. How's the time? Okay. Now I've came across this slide, and I like this slide because it reminded me of my summer holiday, and I was on Great Barrow Island and on Medlands Beach, and if you've ever been there, it's just a fantastic part of the world. But Great Barrow Island is known for its shark population, and there's a lot of bronze whalers swimming around. And anyway, I was out surfing with my 10-year-old daughter, Izzy, and it was very small waves, and it was it seemed like a kind of fairly docile, innocent kind of day, and we were probably 25 or 30 metres offshore, not far, and but a wee way up from the breaking waves. And I was there with Izzy, chatting to her and trying to get her to surf, and there was a bit of yelling and waving on the beach, and then I heard the word shark. And so I thought, oh, we better get out of here and better come in. There was a lot of waving, come in. And so I told Izzy to grab my leg rope and come close, and I paddled her in as fast as I could. And she was, she was kind of saying, what's happening? And I just said, oh, just hold on, we're just paddling. And so we kind of paddled away, and we're just getting up to the breaking waves. And I thought, I sort of relaxed a bit because I thought, oh, we're getting close and it can't be there. And then just as I was doing that, this thing swam underneath mine, and Izzy bored. And I can't say how long it was, but I can tell you it was at least that wide. It was wider than me and the board. And so this shark kind of swam right underneath us, and then out, and then we got out, and we saw it we saw it swimming around in the waves, and it was probably at least 10 feet long, and Izzy by this time had worked out it was a shark, and she was berating me, and she was saying, "Why didn't you tell me it was a shark? I thought we were in a rip. Why didn't you say that?" And I said, "Well, I didn't want to scare you. I wanted you to just hold on so we could get in." And she said, "I wouldn't have been scared. I know how to handle sharks." But the point of the story, long story, is that yes, that was I've had some other encounters with sharks, but that was definitely the closest encounter I've had with sharks while surfing. And but I was still out surfing a couple of weeks later, or actually the next day in Great Barrow Island. So that wasn't enough to make me change in terms of, and that's what we've got to be thinking, I guess, when we're looking at working with young people with AOD problems and adults as well. And so traditionally health services, and this is understandable because, but I'm talking about health in general, are based on the assumption that people recognise or believe that they have a problem, that they need help, and importantly, that someone is able to help them for that issue. And in general, that's what CAM's child and adolescent mental health services are dealing with on the whole. Families and young people coming with feelings of distress, or things aren't right for them, and they're wanting change and they're wanting help. And a lot of CAM services in New Zealand have been kind of overwhelmed, and they end up with a waiting list. And so we have CAPA, which is a demand management, largely a demand management and triage tool. But what happens when you've got a population who have a low or inconsistent, there's a low or inconsistent demand for the service, but there is a high need, so we're trying to access them. And those kind of services need ability to kind of reach out, and as well time to build trust and relationships and persuade people about the value of change. And yeah, so for that, for a youth AOD service, CAPA, a system like CAPA is not necessarily going to fit the bill, because it's not going to necessarily be able to do those things. That said, when you're in a situation where you have a waiting list and you have demand for your service and there's a lineup of people, a waiting list is certainly no way to manage that demand or manage that, you can't make a decision about who needs the care the most and most urgently by putting them on a waiting list. It doesn't work that way. And so CAP is a really good thing at doing that. So I'm not running CAPA down in that situation, but in the situation that we often deal with, where we have need out there, but the young people don't necessarily see that they require help at that point, and we need to persuade them and engage them around that. the thing. So what are the factors which are associated with engagement and retention in treatment? Well, this is kind of part of another talk which I've given to various forums. I'm not going to go into this in detail, but I guess the point is that we can be guided by what consumers tell us, which is really valuable, and by what we kind of naturally know from the fact that we run services and we know something about that from doing that. But what's here is, this is what the evidence tells us that is good for engagement. So there's research that's been done on this, and so we need to take notice of it. And those are 7 kind of areas where there's sort of the best knowledge is around, and this kind of thing is discussed in the CEP guidelines of the Wiri Centre. But I'll just talk briefly about some of them. So service responsiveness. Obviously, these 4 things up here, what one would imagine are self-evident, and everyone is doing that in their service. But I think the point is, we know that this is what creates engagement, and so how often are you looking back at your service and saying, oh, actually, are we these things? Are we flexible? Are we, respectful and trustworthy? So I guess that's the point about that first thing is, you need to ask yourself the question, is this happening? Realistic goal setting. I guess this is about, I think the research shows that services that work with the young person's goals, or the young person's goals primarily, are much more likely to be successful than those that are working with goals of family, or the school's goals, or the community's goals around what a young person should be doing. And I think this boils down to the fact that when we're thinking about treatment in the addiction sphere, I think we get ahead of ourselves when we think that we can, that the treatment goal should be stopping this young person's substance use, or making them use safely, or something like that. Because I don't think we're effective at that. I think what we're effective at doing, let me get this right, is we're effective at showing young people that they can make a choice, showing young people that if they want to make a choice, that these are the options that they can make a choice around, and we're effective at empowering them and making them sort of make a better choice than they have been, and doing that. But in the end, the choice is going to be theirs in the end to a large extent, and that's why this kind of research result, if you like, that around the goals is, I think that's kind of what it's getting at. And what we also know is that if we look at people who come into the service and we ask them and we look at what they want to achieve at that point, it doesn't bear much correlation to what they want to achieve or what they have achieved when they leave. And this is because at the point of coming into the service, they may not even be at the point of recognising that there is an issue. And so that work's done, their insight's been built, if you like, and then they start making changes. So we can't, so we need to be working with, what's happening with that young person at that time. Therapeutic alliance and family involvement, these are kind of other key things. I guess the point about therapeutic alliance there is, and this is my main problem with Kappa. Kappa is pretty good in general. My main problem is that young people come in and they have a triage choice assessment with one person, and then they get put into therapy with someone else. And this is completely contrary to everything we know about engaging with young people and working kind of in that kind of way. We really need to not be jumping clients and young people from clinician to clinician, and we need to try and focus on that engagement and therapeutic relationship as the first key thing. And why is this? Well, I think what happens is we get overexcited about our intervention models, and we think, well, this is evidence-based and we need to apply this for this problem, and this is evidence-based and we need to apply this to this problem. And that's all very well, and we do need to do that because the alternative is doing nothing and ad hoc and crazy kind of care. But on the other hand, we also need to bear in mind that in terms of outcome, it's only sort of 30 to 40% of 30 to 40% of positive outcome for all therapies is related to the actual intervention that's done, and the rest is therapist factors, and so the actual innate qualities of whoever's doing the therapy. So it doesn't matter if they're doing CBT or they're doing IPT or they're doing motivational interviewing, that person's likely to have, if they're kind of a good therapist who forms a good bond and good engagement, they will be more effective than a poor therapist who's doing really, really good care. So so that's kind of the key thing around therapeutic alliance. And then family involvement, I think the risks that youth AOD services have, and which I guess I'm policing all the time in my service and the supervisors I work with is too little family involvement, and you end up with too much of a youth focus. And we've got to remember in youth services, and this is different from CAMS, because that treatment outcomes are way better with family involvement, and engagement's going to be likely to be better too. Okay, so moving on, this is the third issue. Now this diagram is, let's look at the time. This diagram is one that I've done for the talk that Peter was talking about, and the paper in terms of 2009, trying to sort of envisage where effective youth alcohol drug services would sit within the scheme of services in general, and I found it and I put it into this talk, and then I realised that it's kind of confusing and probably nonsense, and I don't know what I was thinking of at the time, but probably the useful bits of it are down the left in terms of the range of things that a well-equipped youth AOD service would hopefully at some point be able to provide. But what I found up in the corner there was primary care, and I think this is going to be, as Peter was saying, this is kind of, I think once services are developed, the links with primary care are going to be a key area which we want to do better, and so that it's this whole thing about primary care liaison. And so, Rick asked me to talk about primary care liaison, and I don't really know much about this, but I'm going to be learning, because we've recently got 3 positions which are in Aldertai, which are particularly earmarked for this, around this primary care liaison role, and there's expectations from the ministry that we will be, I guess, looking at different ways that this can occur, and looking at optimal methods so that that can be other services around the country, CAMS and AOD, can be helped with that. But so I don't know much about it, and I think Sue's here and she's going to talk to us about that this afternoon. But I did think about it a little bit, and the cynical part of me found this slide and that appealed to me, so I don't actually think this, but jokes, yeah. But what is I think it does remind us that what is the point, and just talking to people all the time, you've got to be kind of wary of that. And so I think when we're talking about primary care liaison, what we need to keep in focus is what is effective. Well, you've got to look at what's kind of going to come as a result of that liaison, and if that contact or liaison leads to improvement in a young person's well-being or minimisation of harm around their use, then you're on the money. But if it's just another kind of talk fester, I guess it's just useful to kind of bear that in mind. And so, in the field that we're in, examples might be appropriate referrals from primary care, brief alcohol and drug interventions, or indeed longer ones. So what's primary care for youth? Well, if you've got a family doctor and a family to take you to a family doctor, that's all good. You're one of these good help getters. But that's my time up. But I don't know what people think, but if you try to think about what primary care is for youth and try and pin it down, rest assured youth will find somewhere, they'll find somewhere else. So I wonder if it is actually anything that's not a secondary or tertiary service. We need to be not picky about what primary care is or designate it, but rather we need to look at where young people are, and then we say, oh, that's where primary care is, or that's where it should be. And so I guess we have this traditional model of thinking of primary care as a family or a young person goes via primary care, and there's some sort of triage assessment that can then they can be directed to A, B or C, which are the sort of specialist services that they need. But in the case of young people, I don't think that model's serving them well. And rather wherever the young person ends up, and they might start at A, B or C, so A being altered higher youth service, that should be the point from which they are engaged into primary care. So rather than sort of this idea of going from the family through the GP to specialist services, all areas of the health system should be available to some extent, and their job is to get that person back into primary care. So what AOD work can we do in AOD in primary care? Well, a lot, but again, primary care need time, training, and effective backup. There's good evidence for brief interventions, but the research doesn't really transpire to the reality very well. And I think this is exemplified by, I did a training on brief interventions with the ED staff at Starship last year sometime, and at the end of it, the clinical director of Starship came up to me and he said, oh no, that was great, but have you, it's all nice to hear about brief interventions, but have you got a brief intervention you can do in 2 minutes? And so that's a challenge, I guess. And the other thing I thought about when thinking about this question of primary care is what you do need, I think, to have good, effective care in primary care is at the hard end, the pointy end, you need services that will pick the problem up and take over and do that effectively. So you need a strong specialist service to the really hard end to say, no, this is our problem and we're going to deal with that. And if you've got that, then these other steps and these other things. I've got the questions rather than what they could do. The questions that a primary care professional might be asking, okay, so you want me to do AOD stuff? What should I do then? So the specialist service should be there to be able to tell them what to do, show them how to do it, be there for the primary care agency to check in, oh, well, I've been doing these brief intervention things, is that okay, is that good, is that okay? And if this isn't working or I need help, can I call you? This is getting hard, help me specifically, or I need to hand this on. So this is the kind of liaison and the connection that that's probably likely to be required for it to be effective. And if that is there, this wedge, if you like, can kind of sit there, and the top of the wedge is lots of young people, and lots of young people can be seen in primary care. But I think if you haven't got kind of the strong foundation, that wedge will go up and the primary care will be only seeing a few of them. So be interesting to see what people, I think this is a kind of key discussion point for later. And here's just some examples of some things that might be, and they just off the top of my head, and other people have other ideas. So just to sum up, I talked first about youth AOD services and CAMS, and why I think that having separate services which do similar things but have slightly different focus leads to a strong kind of system for mental health and addiction. Talked about the importance of engagement-focused services, and And what CAP has done is that I think CAM services now better understand the people coming through because they haven't got a waiting list and they're triaging and stuff like that. And it's also taught CAMs to let go of patients in terms of having people on their books for a long time. But I'm hoping that CAPA can adapt and be more engagement focused in the future. And certainly I think that AOD services need to be that from the outset. And then finally, we talked about primary care interventions and how I think this is a key area which can provide, you know, a lot of, well, the evidence would tell us that if we had effective brief interventions in primary care, the minimisation of harm from that across the board would be much more than you could ever do in terms of what you can do in specialist services. But I think the specialist services are required there to support better primary care initiatives, and I guess the history of the sector is that we have these brief interventions and other kind of treatments that have been shown to work, but we don't put it into practice very well. So hopefully that will help with the new initiatives around transition planning and focus on primary care.